to talk for me this morning about your role at the RCM, but also about the series of articles you've been writing for the journal on monitoring matters with long-term conditions. I wanted you first, could you just tell us a bit more about your different roles and how they fit together?
Yeah, of course. So firstly, thanks for having me. Great to be here. So working across a few different roles at the moment, but my background experience has always been within primary care. So started off as a GPN and moved into an advanced nurse practitioner role, and still working in primary care, specialising in long-term conditions within that, particularly diabetes. Now I find myself, I'm in this amazing role as the UK professional lead for long-term conditions here at the Royal College of Nursing. So within that, I'm really lucky to work with some amazing nurses, supporting all areas of long-term conditions. Particularly, I'm supporting the diabetes and cancer portfolios, and working, shaping national nursing policy, looking at workforce, looking at clinical education and guidance, and obviously been working with the Journal of GPN for a while now as an editorial board member. So really great to be here, and hope that gives a bit of overview of some of the different roles you can do as well, being as a background in primary care.
Thank you. That's brilliant and fantastic to hear about all the different things that you're doing to support us as general practice nurses. So thank you for that. Can you tell me a bit more about what you see as the sort of key role for general practice nurses in supporting people with long-term conditions, and also about monitoring those?
Yeah, definitely. Well, I think firstly we need to just understand the value that GPNs bring, particularly when it comes to long-term condition management within primary care. Really essential that we're supporting our nursing staff to feel they have the right skills and the confidence to support patients, because patients are becoming more complex, and it's really important, as I say, that nurses understand where they can find the evidence and who they can escalate any concerns to, and as I said, they can build their skills and confidence in this area. But particularly in terms of the key role GPNs and other nursing staff bring for long-term conditions is around, firstly, prevention. Health promotion, prevention is really important in primary care. We're seeing the gatekeeper, that first point of access for patients. And if we can, prevention is always better than cure. And if we can really support our patients to be looking at healthy lifestyles, reducing their risk, that's really key to reducing further complications and this issue of multimorbidity, which I'll probably talk about a lot today when we have our chat, Jackie. But also screening is really important. It's a really vital role for GPNs, particularly around, as I say, if we're looking at things like cancer screening, but also screening for other conditions such as high blood pressure, if they've got high cholesterol. Really, that's what I think is really key for GPNs, to look at this holistic approach in terms of not being disease focused and recognizing how they all link together. It's really key and really important. We're looking at that for the future of our patients as well. Particularly, it's also with nurses, what the brilliance that GPNs bring is around not just pharmacological treatments, which a lot of our GPNs are skilled in, but also the non-pharmacological approaches. So again, having those conversations, looking at lifestyle, looking at what interventions are available that may not be reliant, focused on, or solely on, I should say, pharmacological aspects. An example of this, if I think of the new weight management program we have available in England for type 2 diabetes, with that, actually what the evidence is showing is that patients want that support with lifestyle, and that medicine may not always be the first option for them. So I think, again, GPNs are really key when it comes to that. But again, it's just also about coordinating care. I think GPNs are really essential for this, in that, we've got a patient in the room with you who may have lots of different conditions or different concerns, maybe not related to their condition. So it's how they can work as a multidisciplinary team, with that be physios, OTs, social prescribers, to provide that support. And then I think finally, one of the key aspects is being an advocate for patients as well. GPNs are really key at that, and making sure that they understand what their patients need and who they may need to go to ensure that they have the right care. And yes, as I say, really must make sure we never underestimate the value of GPNs in terms of long-term condition management.
Thank you so much. That really is really summarises the role really well. Sometimes it's hard to really articulate what we do, but I really feel that you've sort of hit a lot of buttons there for me. And I totally agree. You know, prevention, so key at the beginning. It's so satisfying if you really do make a difference. And I can look back and see people where, you know, you've caught things early on and really made the changes. And I agree, the whole lifestyle changes, when people make those, it's brilliant, and it can be far more effective than medicines often. It can reverse their conditions. So I suppose we are in a very important and powerful role for making those changes. So thank you. Callum, what do you feel are the main challenges that GPNs and general practice staff face, you know, when caring for people with long-term conditions and helping them monitor their health?
Yeah, I think particularly the first one we need to consider when it comes to this is for GPNs is that idea of this competing priorities, recognising that GPNs are working across many different areas. They're looking at wound care, women's health, immunisations, and that all comes into this aspect of time. I think that's one of the biggest sort of challenges that our nursing staff face when it comes to supporting patients, not having enough time to have those conversations, have enough time to do all those checks and risk assessments. But again, that's why it's really important that, you know, as organisations, we're there supporting GPNs and ensuring they've got access to the right resources, the right sort of skills and assessment and education to support them in that time, and help ensure when they do have those conversations with patients that they're able to capture all that information and look at that in a bit more detail. But again, I do really appreciate time is an issue or a challenge, I should say, when it comes to long-term conditions. But I think looking at it from a patient to nurse relationship particularly, I think it's understanding the issue around engagement and motivation. For a lot of patients, they may be living with long-term conditions for many years and who may not have complications, which is really great. That's obviously a really good outcome we want. But as part of that, sometimes we may find that patients don't quite understand those risks. And if they feel okay at the time of their appointment or their checkup, they may not, again, feel that they need to consider the future and what risks they may be at. So, again, I think that can be a challenge for GPNs, trying to keep people motivated when, again, they may have lots of other conditions linked to multimorbidity. Again, that can be quite difficult, trying to that challenge of complexity and supporting patients, in one appointment with lots of different issues. I also think access to services. I think if we're looking now at long-term conditions, unfortunately, we're seeing a lot of younger patients develop long-term conditions. If I take diabetes, for example, type 2 diabetes, seeing a much younger age range between the ages of 18 to 39 years of age. So again, we've got to recognise these patients are going to be living with that long-term condition for many years. But if they're working age or they've got a busy family life, sometimes that sort of 9 to 5 an appointment in the week may not be as accessible. So I think that can be a challenge for GPNs as well, and that comes back to that engagement and motivation. If it's not the right time or the right access for that patient, how are we going to engage them in their healthcare and make sure they've got that support? And then I think come back to this younger patient aspect as well. I think as a GPN, we sort of talked about, as that first point of contact. For many younger patients, they may, we need to be looking at aspects of contraception. We need to look at psychological, reducing their long-term risks. And it's about, again, for GPNs having that skills holistically to recognise all those different things in an appointment. So, yeah, I think, unfortunately, there are a few challenges, but I think that's where it's just really important as organisations we support with that education and training and providing opportunities to recognise what resources are available to support GPNs in practice.
Yeah, that's very helpful actually to think about. It helps me to think about, times where someone comes in and we've maybe got our agenda of an asthma review, but actually you find out that the person's in a different sort of space and actually signposting to a mental health nurse or just managing the sort of complexity. It's not, it's a whole person, isn't it? That's the thing that we have to manage within that. And good consultation skills helps, and prioritising helps. But we are, I think, more and more faced with increasing complexity, and that can be difficult because it's okay in a clinic to have one or two people that you run a bit over with, but when you're finding that everybody's got some complexity, then that can become it can start to lead to burnout, really. So finding ways to manage that effectively is really, really important. So yeah, thank you for that. It's really good. So what advice would you give to nurses thinking about becoming involved in monitoring long-term conditions? I mean, we've talked a bit about the complexity there, and I think it's so important that that is recognised in general practice nursing. It isn't really now just a matter of a simple asthma review, a simple diabetic review. We've got this multi-morbidity, and like you're saying, we've got younger people coming through. There's so many different aspects, and as we touched on earlier, prevention and helping people engage in prevention is absolutely key too. It's a big role. It's a big role. It's an exciting role. Can be very satisfying as well. What would you advise?
Yeah, no, I agree with all the points you make there. And I think it's just recognising as a GPN that confidence around that transferable holistic skills you'll bring outside of long-term condition management. Well, as GPNs, we're seeing patients of all age ranges with lots of different medical or nursing needs as such. So it's really important that we are recognising the GPNs. You've got a lot of skills there, and it's just applying that when you're looking at long-term conditions to the guidelines, sort of formularies, all those things that are sort of local to your area as well, and what services are available. So I think it's, again, just recognising GPNs have the confidence, because you're already probably doing a lot of this work, as we've mentioned, around sort of health promotion screening. It's just around looking at what guidance is available to support you. And I think this is where also from an employer perspective, that's really important, that the employer supports our GPN to be able to undertake that formalised training, have that supervision as well to really make sure they feel confident in practice. I think, again, unfortunately, in sort of the aspects of primary care at the minute, just due to the nature of how busy things are and how many patients we have, we're finding a lot of nursing staff are going on courses, getting that education, but then sometimes not getting the supervision in practice. And it's about that applying theory to practice, and that's a really important aspect. So I think, that's some advice I would make for GPNs to be thinking about, is if you're looking at doing education, just make sure there's those supervision processes in place as well. And again, when I look at, after you've done that course, you've had that supervision, what best practice evidence is available? And obviously looking at resources from the General Practice Nursing at RCN, you've got all these different guidelines and sort of resources are available as well. And that helps you make informed decisions, but also recognising that patient-centred care is really crucial at care planning. And we talked about that agenda earlier, and I think that's a really good point you make around a healthcare professional. We sometimes may look at some patients' notes, get a bit of an idea and think, right, this is what we need to focus on. But when they come into the room, they may have something completely different they want to talk about and look at. So again, it's why it's really important that you've got that evidence base there, what resources are available and who you may need to contact. And I think I can't stress enough this most important part of multi-morbidity, which you've hit on again. It's because then it'll be probably a theme of our conversation today, but it's so important that we're looking at patients not in that single context of, okay, they have diabetes, this is what we're going to focus on, their sugars. Well, actually, they can have diabetes, high blood pressure, high cholesterol, poor kidney function. And even if GPNs may not feel they've got the skills to manage all of that, it's about how, again, they can look at that prevention, screening and escalation potentially to other services or practitioners who can support them. But I think the last point I'd like to end on, and we talked about time again, is this planning adequate time of clinics. Okay, it can be difficult. There isn't sort of a lot of set guidelines to say, if you're doing this review, this is how much you should get. It's dependent on lots of other sort of individual and local factors. But I think as GPNs, again, having that confidence to recognise for themselves at where they may be in that stage of learning or supervision or skill and confidence, what time they may need for an asthma review, for a diabetes review, for a hypertension review, recognising that and planning that, again, with the other sort of care and clinical team to ensure that you're providing that right care at the right time. They would be, those points of advice I would give GPNs at this stage if they're looking at moving into the world of long-term conditions. And as I said, likely a lot of GPNs, even if they haven't got the formalised training, may already be doing this as such. But I really would just say encourage them to have those discussions with employers, make sure they've got that education and supervision, and utilise that evidence for best practice, definitely.
That's really helpful. Thank you for that. And I think, I've been doing quite a bit of supervision of new GPNs on different courses, and being accessible to them and finding different ways to supervise has been really interesting. Sometimes we do remote sessions, which is really nice because I can see the notes across all 4 practices, and or they'll send me the ones that they've struggled with, after they've done the course, and they're starting to do their reviews. They can send through people they're worried about, and I can check up on that and consult them myself by phone if I need to. So it's been very interesting finding different ways to do that, as well as, of course, going and sitting in on a shared clinic, which I really enjoy as well. But with the busyness, we've been finding other ways to manage things, which has been good. Callum, can we talk a bit more now about how general practice nurses can be supported to monitor, these often quite complex patients, and how you see that being best achieved for new and established nurses?
Yeah, definitely. I think it's a real key aspect. I think, as we've sort of alluded to throughout the talk today, when we're sort of seeing practice nurses, they're obviously hitting the ground running, doing lots of different things and lots of different clinics. But it's just about having that time, again, consolidating education, supervision, making sure there's enough time in those clinics. But I think a really important part, and we talked about team working, is working as a team when it comes to long-term conditions, making sure you've got the opportunity to have a debrief. I look back when I first started doing diabetes, and I worked with a really great advanced nurse practitioner who we had protected time at the end of our clinics to go through patients, understand, was this the right course of treatment? Could there be anything else we can improve on? And again, that really gave me the opportunity as a GPN to consolidate that skill and learning understanding. And I think that's really important, that debriefing, but also the opportunity to discuss with other colleagues. We are, not one size fits all in long-term conditions. And, other people may find that they've got different ideas and different ways of discussing things with patients as well. So I think that's a real key sort of area of support, and would highly recommend that GPNs are finding that. And we do know in primary care that some GPNs may be the sole nurse who's working in diabetes and respiratory, but there's lots of different clinical networks. Obviously, out here at the RCN, we have forums. Obviously, general practice nursing, you have lots of different individuals who are reading that magazine, who are involved with it as well. So I think it's really important. People are even if they haven't got it locally, they're reaching out to when I say local, sorry, in their own surgery, but even if reaching out to their local area or different networks that are available to sort of seek that advice and support is really key. And I think finally on this point, what I'd like to add, which is really important, and what is obviously a lot of work that we do in supporting nurses in the different roles that I'm doing particularly, is making sure that GPNs feel confident not to work outside the scope of their practice or of their ability. It can be quite easy in primary care because of that complexity, because of staff shortages, because the amount of patients we are seeing in a day, that sometimes you may find that we're trying to manage lots of different things, and actually is recognizing, are you the right person to deal with that right concern at that time, and not being afraid to escalate that care, and explaining that to the patient, and saying, look, at this stage, I might not be the best person who can be supported with that. However, we could look at supporting it with the social prescriber, with the GP, with the OT, physio, those different people. Again, that MDT approach. So just really would give that, say, as advice for GPNs wanting support. Make sure that you feel you're always working within your scope of practice. And if you do have concerns, escalating it to the right individual, definitely.
Yeah, absolutely. I totally agree. And I think sometimes GPNs will sit in with me, and I'm an AMP and a GPN, so I can obviously do the diagnostic elements and all of these things. But I've actually, when I'm training them to newly do asthma clinics, I'm now actually pre-selecting the patients, because I was finding that in this busy world, if patients selected themselves and filled the clinic, they were the really complex ones. And you want people to be able to start with a simple asthma review, which doesn't involve working out, actually, is this diagnosis even right? Or is the shortness of breath coming from some other issues? COPD, have they also got heart failure with their shortness of breath if it's not responding? So I think that's so important that they can recognise that, like you say, and then seek support. Also totally agree that, the learning on the job, the chance to discuss cases, for all of us, however long we've been working as general practice nurses, is hugely valuable. And I find the different groups that I'm able to do that in are greatly beneficial. We've got local clusters, like you say, there's things through the journal of general practice nursing, the RCN. I really enjoyed teaching on the NEST GPM pathway, and what that, you learn. You're not just, I'm a clinical facilitator, but you're not just teaching, you're learning so much from these new nurses coming through with their transferable skills, with the new things they've picked up on, often hotter on IT than we might be. And no, I'm not sorry, I wasn't saying that you weren't there. You're probably very good. I know that I can be a bit rusty at times. But yeah, it's just fantastic. And in the really busy world of trying to see a lot of patients, making that time is so valuable. So yeah, thank you.
No, I mean, I think you talked right there about that fundamentals of care, and I think that's really important in long-term conditions, looking at the fundamentals of a condition, and then, as you say, naturally when your confidence and skills grow, then those other aspects of sort of differential diagnosis, multimorbidity may come in, but it's just really understanding the fundamentals to support you. I think, yeah, a really key point, and I think you're completely right there, and it's great to see that, you know, GPNs who are working with you have that opportunity to do that through your clinics.
Callum, I've really enjoyed reading the series Monitoring Matters that you've been doing for the general practice nursing, and with each one I've picked up extra ideas of how I can do things slightly differently and things like that. So thank you. It's been really good to reflect on them afterwards. So firstly, I wanted to ask you, can you tell me a little bit more about blood pressure and how you adapt? Because I find this quite important in my practice, about adapting blood pressure targets to different conditions with people with multimorbidity or frailty or different patient populations.
Yeah, no, it's a real key aspect we need to be looking at in practice now, because I think we've alluded to, again, multimorbidity, one size doesn't fit all, and this complexity that comes into it. And I think it's really important in the context of long-term conditions that we address this holistic, person-centered approach, that what we might use for one treatment, even on the guidelines, may not actually be right for another. And I think that's just really important that it comes into that, getting that fundamentals of that condition, and when you're building skills and confidence, and again, working with other sort of colleagues to recognise, is this right? Do I need to be thinking about something else? And I'd done a presentation recently through the RCN, and within that I put at the end of my slide, think about treatments, think about quality of life, BMI, renal function, because we need to be addressing this cardiometabolic holistic approach. Think about, psychological aspects, the burden of a long-term condition as well. That's really important to remember. It's exhausting if we think about it. You've got all these medications, you've been having all these appointments, all these reviews. So actually we need to understand it in some patient's context. Are we doing the right thing? And I think if we particularly look at blood pressure management, it's recognising that this balance between, for those who are maybe more frail and maybe in the later stages of life, do we need as tighter controlled targets? And maybe those who are more younger with other multimorbidity, actually we might need to be a bit more aggressive with the treatment to reduce those long-term aspects. And I think it's, we all have QOF and we have those different things to work to, but actually, again, that doesn't take away the art of clinical assessment and judgment with a patient. So I think it's just really important in blood pressure particularly, we're looking at that sort of those different stages of life from younger to the later and where patients may fit within that. I also think it's important to look at different ethnic backgrounds, particularly when it comes to blood pressure management. As per the NICE guidance, we know there's different treatments depending on patients' different backgrounds. So that's a really important aspect to remember, alongside sort of BMI measurements, because that may be different in this ethnic group, which could impact on, again, how we titrate treatment, etc. But I think it's really important that GPNs feel confident to understand that actually, if we've got a patient who may be in that late stage of life, more frail, maybe we could look at relaxing their targets a little bit, prevent the risk of falls, other complications. And also for patients as well, it comes into this big issue of polypharmacy, something I'm quite passionate about. And actually I've written for the journal before around de-prescribing, mainly in diabetes, but actually in long-term conditions. I think it's really important. We're very good sometimes to add medications, but when do we need to look at sort of stripping those back to support patients? Some patients don't want to be on lots of medications. They find it a challenge. And actually, if they're not going to take them, or they don't understand what they're for or why they're needed, could there be better options we could look at? Or actually, could we look at stopping it and relaxing that target? But then on the flip side, for those younger patients, particularly around blood pressure, we may need to consider, actually, do we need to try and reduce the targets a bit, particularly if they're living with multimorbidity, so if they've got high blood pressure and diabetes, high blood pressure, kidney disease, we need to probably be looking at bringing that blood pressure down to as low a target as recommended, or even below that, so we can reduce that risk of end organ damage. But again, my advice around blood pressure sort of adaptation when it comes for GPNs is that holistic assessment, risk assessment, utilising the guidance available, but also the pharmacological but the non-pharmacological approaches around diet, lifestyle, weight reduction as well, because it's really important that we're sort of ensuring patients see how it can impact on all different areas of their life and what they may need to do outside of that clinic wall. We think on average a patient will probably see a GPN probably 1 to 2 hours a year for their long-term condition. The rest of the time they're managing that independently. But it's just that's where you may need to adapt again how you have these discussions with patients and what targets you set depending on sort of age, frailty and other conditions that come into it. So I hope that gives a bit of a sort of support to GPNs as well.
That definitely does. And it makes me think about there's a lot of negotiation within that consultation, a lot of explaining risk benefit. So there's the education that takes part, and then really a joint agreement and a joint plan, which is so important, because if people truly understand and you've documented that, then they can make their own choices, which I think is so important. And sometimes just last week I saw someone totally turn it around with lifestyle, and that's so great when they manage to do that. So it is about ensuring they have the information and the tools, and then that negotiation around it, and I suppose being aware, like you're saying, of all the different guidelines and which blood pressure target do we need to work at, and this person's a younger person, and protecting their kidneys and all of that. So it's a lot to keep in your head, isn't it? But
it really is. And I think it's again about not being afraid to say potentially at that time of the patient, look, I may need to consult with a colleague, or actually we may need to bring you back. But it's about making, and again, small changes at that time can have a good long-term impact. But it is, you're right, there's a real lot to sort of hold in your head and in a consultation. But I really liked what you talked about in terms of that agreement with the patient, working together. As I said, I think sometimes we can get very dependent, and we're understandably, we've got lots of patients waiting, lots of sort of things we need to get through in a consultation, and it can be very easy to sort of look at your list and go, right, this is what we need to work to. But actually, again, that may not be the right thing for that patient. Yes, they may want to get their blood pressure down, but actually they're really concerned about their weight. Well, actually, if we help them with weight, that will also help their blood pressure naturally. So it's about those different things, as you say, having that agreement is really key.
Yes, it's a constant balancing act, but
definitely.
That's great. Yeah. So actually moving on to weight management, it's pretty hot topic in the news at present as well. I'm seeing a lot coming through on that, which I think is quite exciting, but I'm wondering how it's all going to fit together. Do you have any advice about how we tackle this issue? So many people are struggling with it and often struggled with it for so long. And we need to do it in a way that's both has empathy, but is also effective within what is often an extremely busy clinic.
Yeah, definitely. You're right. It's I can probably say majority of my clinics around long-term conditions, I'm having these discussions at the minute, and you're right, they're not easy. It can be difficult, and again, when you've got all these different things you're taking into consideration, and actually for a lot of people, they may struggle to address that as well. But or we get the flip side where patients are very open about it and really want to have those discussions. So I think in terms of sort of looking at in a busy clinic and how do we address this, I think first it's just understanding the individual concerns. Again, going back to that patient, what is more important for them? Yes, it may be their weight, but actually they're struggling with their weight because they've got a knee problem, so they can't exercise. So again, it's just how we can address those small little factors first. But again, I want GPNs to feel confident to recognise it may not be everything you do there, but you can start that conversation and support patients to come back or seek other services or advice to recognise how they can begin to address that change. I think for me, I always see it as a real positive when patients open up the conversation, because it means they are ready to address change and they want to talk about it. And again, I think sometimes patients feel they can't, or they're worried about talking about it as well. So I think that's just a little sort of a bit of advice I would definitely say to start the conversation. But my next sort of, and written within sort of the article itself, I given some advice around firstly awareness. So again, it's shift that from explaining the risks, but rather ask the patient about what they understand, because we can be very prescriptive in this increased risk of heart disease, stroke, diabetes, cancers. However, actually we need to say then potentially we could say to the patient, what do you know about weight and how it may impact on other conditions? Get that understanding first and see what awareness they have, because that really helps open this conversation and brings the patient involved. They think, okay, actually, what do I know and what do I need to be worried about? So that's, again, that awareness first. The next one is this difficult blame and shame culture. Okay, so it's avoiding words that may blame and shame a patient, but being more open about their unique situation, which could have contributed to their weight problems. Again, we need to understand people have got busy lives. They're doing we've got lots of things happening now and outside of this four walls of a clinic, and there could be lots of reasons they may be struggling. It could be sort of financially, they are sort of not being able to have a healthy diet because of it. They may find that their mood is low, so they find that eating is a way to support that. So again, I think that blame and shame, because it can be quite easy, and when we're being quite judgmental as well, to sort of say, okay, well, we know this X, Y, and Z has caused you to be overweight, but actually, again, working with patients is really key. The next one to talk about is labelling, so avoiding the use of the word sort of obesity. And actually, if we're looking at weight, and as obviously we've talked about this in the article as well, not just being overweight, but underweight as well. So moving away from the terms anorexia and the stigma that can be associated with it. But again, we may be understanding that this person is living with a higher or lower weight. And I think that's how we have to, patients are living in this day situation 24 hours a day with weight wherever that may be, and I think that's really important. And again, just the last part bit is sort of avoiding assumptions. So we need to move away from that, we're just assuming they're not wanting to exercise or they're not wanting to follow a healthy diet, and focus on the positives. If they've made small changes, let's continue with it. Let's award that small win, even if it is £1 here and there, if they've started taking up a bit more exercise. So yeah, those kind of factors I think can help. Again, it's a lot to cover in an appointment, but just some small little snippets of advice. And moving medicine particularly has some great tools you can use in practice, opening up 1 minute or 3 minute conversations around weight management as well. So there would be sort of resources I would suggest GPNs take a look at.
Fantastic. That's really helpful. Thank you. I found it interesting how you were applying in your article weight management to different long-term conditions. I've got quite an interest in respiratory, and I do include a height and weight in my, unless they're remote reviews, I include a height and weight in that, because like you're saying, it is so important, both being underweight and overweight. With respiratory, do you have any resources, for example, a patient with COPD avoiding further weight loss or gain some weight to help their long-term outcomes when they're underweight? Because of course, long-term outcomes with COPD, being underweight is problematic as well as being overweight. Are there any particular resources you use for that?
Yeah, I think firstly it's really great to see we're addressing sort of underweight, because I think it can be something we as I say, within primary care at the minute, it's a very hot topic around being overweight, but underweight has, as we've seen from the article, lots of complications and lots of other long-term conditions. So I think it's really important to discuss that with patients. In terms of sort of resources available, I think there's lots of opportunities, see what you may have. And when I say resources, sort of services you can utilise locally. I think if we're looking at exacerbation risk in someone with COPD, if we may probably finding that their calorie expenditure is quite high because of their breathlessness. So if we're looking at sort of pulmonary rehabilitation, that may be a really good opportunity as a resource to support patients to look at reducing that shortness of breath and helping them when it comes to, not trying to lose weight from their calorie expenditure. And again, another resource I would say to utilise is the dietitian or dietetic team. If a patient's BMI is below and is low and they've got a must score that's raised, etc., or fits within that guidance, or outside of that, you can ask the dietetic teams for advice, looking at ways that may support with nutritional supplements, sort of drinks, meal replacements to help again with that calorie intake and increase that. Whilst addressing the breathlessness, I think that's really key as well. We need to look at that underlying cause. And I think, again, we talked about the fundamentals and then maybe looking about how this can consider other diagnoses. But if we've got a patient with COPD losing a lot of weight and their symptoms are quite well managed or, stable as such, we may need to consider, is there something else going on? Looking at cancers and things like that as well. So it's always having these things in the back of your mind, and never be afraid to work with the MDT. Really important again that we're working with a physio team, obviously respiratory team, those specialists who can have a look, be involved and support patients when it comes to weight. And the Eat Well guide I find really useful for sort of supporting patients to recognise, yes, is their plate, but actually in this situation, if you're losing a lot of weight because of your breathlessness, we may need to increase your fat intake. And this is some things we can do. A lot of patients always like to add ice cream to their drinks or have those high calorie soups and things. So there's some, again, resources that that GPNs can look at to support patients. So it's just a really important concept, as you say, about the risks of being underweight as well. We can often forget that because we're very busy and we've got a lot of sort of support and time being focused and being overweight, but it is really essential we're considering it in those reviews. So again, hope that just gives some ideas of sort of resources, but sort of services and advice that people can use in those consultations.
Yeah, no, that's super. A nice sort of broad look at it all, and also identifying, is this actually a red flag as well, and who else in your team can help you with that. Very, very helpful. Thank you. Thanks. With asthma or COPD, how do you tease out and address weight management when you suspect someone's shortness of breath is caused more by their weight than their asthma or COPD? And I was I think this reminds me of a recent consultation where I knew that if I referred back to respiratory, this is what they were going to be saying. So it can be really hard to address that with someone, and sometimes they don't want to hear that, but actually it has a massive impact on your lungs. I find myself trying to explain anatomy and the diaphragm and all of these things. How do you tackle that?
Yeah, I think firstly it's a good way you talk about it, and that would be a bit of advice I would go with, is again maybe moving back to that, not sort of this is your risks, this is what could happen, but actually seeing what the patient understands when it comes to their respiratory condition and being overweight. Because as you say, sometimes patients may not want to address it, but it's not until you've opened that conversation and realised that patients may not understand, they may not consider that as a risk. They may be thinking, oh, it's my asthma flaring up, or actually, I've got I'm working in a new environment with dusty, that could be which could be a cause. However, again, we need to that fundamentals, looking at that holistic approach and go, this could be something we need to address. And they aren't easy conversations. But I think, again, it's really important we explain how the pathophysiology behind it, the condition, how it is impacted by weight. And again, looking at those similar conversations with no blame, not making assumptions, but again, utilising services that are available. If they, depending on what is there in terms of weight management, we've got tier 1, tier 2, tier 3 services in terms of weight management that could be available local area. Think about utilising them. And again, that multi-morbidity, I've talked about it a lot today, but with being overweight with a respiratory condition, we know it's going to impact on their symptoms. And particularly if we look at their use of reliever therapy, we may find that patients may overuse reliever therapy because they're feeling short of breath, which then impacts on their asthma, but actually it could be because they're overweight. So I think it's just about, again, working with patients, looking at them in that consultation to understand, right, what medications they're using, how are they using it, what symptoms do they have, can we rule out any other risk factors that may be contributing to it, and if we're still finding that actually weight is one of the main issues, then again, coming back to those sort of skills or a bit of advice we talked about earlier in terms of how to address that in a consultation. But for me, what's really important is, again, utilising the other services available, and particularly what we find for patients, if we think of those who are asthmatic, obviously they are paying for their medications, depending on their age, they will be paying for their medications in England if we're looking at it from that perspective. And actually that, financially, that could be quite difficult. So then again, looking at that impact it could have on their lifestyle and diet because of that. And that's where utilising sort of working with social prescribers and their MDT, again, are really key when it comes to this, because it's a multifactorial cause for obesity. We know it's not sort of, again, that one size fit all, one problem means everyone's overweight. Actually, there could be lots of individual areas we need to look at and address. So yeah, I think overall you probably see it's not an easy conversation. I think there's lots of ways you can sort of begin those conversations as well, but really getting good patient understanding what services are available, and really ruling out any other cause that could be contributing their shortness of breath, to highlight to the patient that actually weight is a significant impact.
Brilliant. Yes, thank you. Thank you. That's given me some further ideas there. So thank you.
No, great.
So your lipid article, which will be released in the next issue of the journal, I found that very helpful as well. Again, it stimulated quite a few thinking points and reflection for me. But the key thing for me in that, I was very interested in managing statin intolerance, because I do feel that, managing cholesterol is life-saving, there's no doubt, and statins have been a huge part of that. And so if we can help enable people to take statin treatment, and the evidence does show us that things like muscle intolerance is actually only really about 1 or 2, I think, in 100.
Mm-hmm.
So it isn't as big as sometimes people think. So strategies to enable people to take statins is so important. And I was very interested actually in thinking about your statin holiday strategy. And so what I wanted to find out a bit more about was how you actually do that, how long, or, how do you go about it?
Yeah, I think firstly, sort of picking up on this topic, it's an area I've become really passionate about recently, because I've seen it sort of personally and in practice and in lots of different areas, how lipids are impacting on so many different long-term conditions. So it's really important that we address this. And GPNs are in a great position because they build up really strong therapeutic relationships with patients. They get to know their patients really well. And again, they've got a lot of skills and knowledge that can support around, discussing statins or other cholesterol-lowering medication. And I think, again, even if GPNs aren't initiating, they're in a really, and that's what my article talks about, they're in a really strong position to begin those discussions and get patient understanding and utilise some evidence to give to patients to take away. So yeah, just a bit of my sort of passion on that reason why I'm looking at this in a bit more closely through the article. But particularly when it comes to a statin holiday, the reasons what I've looked at mentioning this, and it's really around understanding, is it the cause of a muscle pain? I think for a lot of patients, we know I know personally from a lot of discussions, straight away it's, I know my friends, my sister, my husband has had loads of problems on it. They've had loads of muscle problems. I can't take it. Again, recognise, well, actually, everyone's different. Everyone have an individual response. But actually, if patients are suffering from muscle pain, let's try stopping it for a couple of weeks, maybe 1 or 2 weeks. Let's give it a bit of time, have that washout period, really allow you to then feel, is this the main cause? And if it is, okay, that's when we go back to the drawing board. If it's not, that's when we can begin looking at other investigations. And I think that for patients gives them that idea that actually, do you know what? It wasn't causing an issue. However, sometimes it can be difficult to get patients to restart again once they've stopped it, because they're, I've stopped it now, I've one less medication. But again, coming back to those long-term risks. And there's a few other tools I use as well when it comes to sort of looking at sort of statins and cholesterol-lowering medication. So the statin holiday is definitely as one, in terms of if patients are having an intolerance, we want a bit of a washout period over a couple of weeks, recognise and say, is that the main cause? And if it is, look at alternatives. If not, then we introduce it and look at other sort of investigations. However, another one is understanding that the NICE, particularly patient decision aids, are really good. You spoke about that earlier, Jaqui, in terms of recognising sort of how many patients may actually suffer from the muscle pain side effects. But I find that's really good because, again, when you're in a consultation, you're doing lots of different things. If I take a new diagnosis appointment for diabetes, I get 30 minutes, well, covering quite a lot within that. And the majority of times that we do find in terms of this metabolic syndrome, a lot of them will have high cholesterol. So I'm trying to address that in a quick format to say, look, we've got all these other things, but this is really important. But sometimes giving some patients some information to go away with, consolidate, digest it, and understand it a bit more in context of all the other conditions they may be suffering with, I think is really great at giving patients that confidence to go, okay, yeah, I know a bit more about it, I've sort of digested it, let's discuss it again. And again, don't be afraid to bring patients back to do that, if you don't have the time. Another really good one I like to use is what I call my car analogy. Okay, so it might not work for everyone, but I find it can help sort of breaks it down a little bit easier for patients. So what I say is our body's like a car. As we get a little bit older, or some things happen to it, we sometimes need to give a bit of a modification to give it a bit of a helping hand. So, and that can be where we look at statins that come into that modification or that bit of a helping hand as well. Because I think we talk about prevention being cure, and if patients aren't unwell and not symptomatic, it can be difficult to say we're going to be putting you on the medication for life to reduce that risks. But again, it's just understanding we're looking at a future aspect, and particularly in our younger patients. I spoke about this a lot today about that younger patients with long-term conditions. I feel that's a real important part of my role here, supporting nurses to recognise, that those younger patients are so crucial. They're really a great opportunity to have that treatment, reduce those risks, and statins will inevitably be a part of that, or other cholesterol lowering medication. And I think, another point I'd like to make, and I know I'm talking lots about cholesterol and statins and different lipids in general, as I see I'm quite passionate about it, but not to be afraid to escalate treatment. And if that's not something, as a GP feel comfortable doing, making sure that they're either escalating or speaking to colleagues, GPs, AMPs, etc., we may be able to do that, or GPNs who are obviously very skilled in this area as well, because we can find primary care, a lot of patients firstly aren't identified as having high cholesterol. So that's in a whole other area we could spend many hours talking about, I'm sure. So identifying the patients, but then also when we do identify them, making sure that they're on the appropriate treatment and escalating it. And there's some great guidelines available for that. You've got the NICE guidelines, there's European Society of Cardiology guidelines, and in England, the NHS England is the National Clinical Summary of Lipid Management as well. So yeah, there's lots of different things that can, so to firstly support you speaking to patients and potentially starting treatment, and then looking at some of those decision aids, car analogy if you find it useful, and that statin holiday as ways to support where patients may have intolerance or feel that that's not the treatment for them. So yeah, I hope that's helped. So I could talk about lipids for a very long time. It's an area I'm quite passionate about at the moment.
That's brilliant, thank you. And I think I'll try the car analogy, because that sounds like a good way to get the message over. So thank you. I like those sort of tricks. Thank you.
Great.
So that really moves me on just to want to ask you about some of the resources with the RCN, because there's so much good stuff out there that often we're not aware of. So it would be really great if you can tell us a little bit about the resources that you have available for us.
Of course, yeah, no, and thank you for allowing me to share it, because it is really important. So for all those who are reading the Journal of General Practice Nurses, who are RCN members or who want to become RCN members, we do have some really great resources to help support you in practice. Really important to recognise, yes, we're a trade union, but also a professional body. And my role here, particularly at the college, is really support primary, secondary care, but obviously my passion is primary care, where I work a lot in. Really support nurses from any background to have access to this education as well. So particularly we have our RCN Learn resources. So on our learning platform, which is having a review at the moment, we've got some great things on there to support you in practice. One close to my heart is our Diabetes Essentials. It gives a really good overview of diabetes, and particularly for those who are non-specialists as well. And we've recently updated it to include information around continuous glucose monitoring. That's very hot now within primary care. So that's a really good sort of resource you can use. However, we've got loads of different areas we focus on. We have one on respiratory assessments, so how to auscultate and listen to chests. We have a nursing guide for supporting patients with learning disabilities, specific for GPNs as well. And then again, if I'm thinking on the context of long-term conditions, and I'm really pleased to say cancer is now being recognised as a long-term condition, not just living with, but beyond cancer. We have a lot about prehabilitation for cancer treatments as well. So yeah, there's some really great resources there. And as we've spoke about before, Jack, I think privately is around the forums as well. The RCN have forums where our members can join. And again, within that, we look at resources, education. We have some quite hot social media sort of channels that we're using around Facebooks and X. And particularly, we have a GPN forum webpage, which is very active. So yeah, would recommend people having a look at them and reaching out to us if there's any ideas as a member. If there's something you want to look at or ways you can get involved, then please do let us know, because there's some really great resources there. As you say, it's just how you access and where they are, but they're all on our RCN webpage. We have our forum web pages as well. So yeah, if you're a member or wanting to become a member, do make sure you take a look, and because it can really help you in practice, particularly with CPD and revalidation as well.
That sounds absolutely fantastic, and I've just made a mental note of a few there that I want to check out soon. So thank you for that.
Problem.
Well, thank you so much for coming and talking to us today. It's been hugely helpful and lots of different ideas, and I just really want to say a big thank you. Is there anything you want to add?
Yeah. Well, firstly, again, I'd like to extend the thanks back to yourselves for having me. It's been a really great opportunity to showcase long-term conditions, because for me, it's a really important aspect of primary care. Our GPN nurses are vital when it comes to supporting patients with long-term conditions, and that's in screening, diagnosis, management. We're seeing patients across the whole lifespan continuum as a GPN. As you said, we're really seeing patients earlier on now. And I just really want to say, thanks again for allowing me the opportunity to come showcase my passion for long-term conditions, but also, again, the value GPNs bring. And if it's an area you're not as confident in or you're thinking about entering, I would highly recommend it, because it will really help improve so many other areas of your practice as well.
Thank you. Thank you for your support for the role and championing what we do. Thank you.
Thank you very much.